Your blood pressure medication may be making your blood pressure problem worse, not through any failure of the drug itself, not through any error in your treatment, but through a side effect that is pharmacologically documented, rarely mentioned at the point of prescribing, and quietly operating in the background of tens of millions of Americans managing hypertension every day. The most commonly prescribed class of blood pressure medications, thiazide diuretics, actively depletes a mineral whose deficiency contributes to elevated blood pressure in the first place. That mineral is magnesium, and the story of what it does, why most people are not getting enough of it, and why the standard blood test used to check for deficiency routinely misses the problem. That story has been sitting in the peer-reviewed literature for decades without making it into the conversation most people have with their doctors. This is not a video about abandoning your medication. It is a video about understanding something your treatment plan may not be accounting for, a physiological mechanism so specific and well-documented that researchers have used the same terminology for it since the 1990s. Magnesium, they have written in cardiology journals, functions as the body's natural calcium channel blocker. The same mechanism that one of the most prescribed drug classes in America is designed to replicate pharmacologically is one the body already has, and most people over 50 are running it at a deficit. What is the test your doctor uses to check magnesium? And why does it miss the most common form of deficiency? How do blood vessels physically change when magnesium is insufficient, in ways a blood pressure cuff cannot capture? And what does any of this have to do with what your blood pressure does at night, while you are asleep, when nobody is watching the numbers? There is a class of medications that cardiologists consider among the most important tools in cardiovascular medicine. Calcium channel blockers, drugs like amlodipine, diltiazem, and verapamil, work by blocking the entry of calcium into the smooth muscle cells lining blood vessel walls. When calcium cannot enter those cells, the muscles relax, the vessels dilate, blood flows with less resistance, and pressure drops. It is an elegant mechanism, well understood, and so effective that calcium channel blockers are prescribed to tens of millions of Americans every year, often for the rest of their lives. What almost nobody mentions, not in the exam room, not in the pharmacy consultation, rarely even in medical literature aimed at patients, is that the human body has its own version of this mechanism, a mineral that competes with calcium at the same cellular entry points, that relaxes vascular smooth muscle through the same basic logic, that simultaneously increases nitric oxide production, improves the function of the cells lining blood vessel walls, and induces vasodilation through both direct and indirect pathways. A mineral the body cannot manufacture on its own, that must come entirely from food or supplementation, and that the majority of American adults over 50 are not consuming in adequate amounts, often without knowing it, and often without any standard blood test flagging the problem. That mineral is magnesium. And the distance between what the science says about it and what most people with high blood pressure have ever been told is one of the more consequential gaps in contemporary cardiovascular care. And according to the American Heart Association, nearly half of all American adults have hypertension. And among those over 60, the prevalence exceeds 70%. Most of them are managing it with medication, with dietary adjustments, or with both. Most of them have been told, at some point, to reduce sodium. Very few of them have ever had a conversation about magnesium that went beyond a brief mention on a wellness website, or the back of a supplement bottle. The conversation about blood pressure management in America has been organized around two pillars for decades. The first is sodium. Reduce it, track it, read every label. The second is medication, when lifestyle modifications prove insufficient, which is often prescribe something. Both pillars are legitimate. The evidence supporting sodium reduction is real, and the evidence for antihypertensive medications is substantial and consistent. But a framework built on only two pillars tends to leave everything else in the shadows. And what has been sitting in those shadows, documented in peer-reviewed research for more than 4 decades, is the role of magnesium in blood pressure regulation. Specific enough, mechanistic enough, and clinically meaningful enough to warrant conversations that most people with hypertension have simply never had. This is not a story about a miracle mineral or a suppressed cure. It is a story about a gap between what research shows and what reaches the patient, with real consequences for people managing blood pressure after 50. Because that body, at 55 or 60, absorbs minerals differently, retains them less efficiently, Sinand is often taking medications that quietly deplete magnesium as a side effect, without anyone mentioning it. Understanding the mechanism comes first, because once you see precisely how magnesium interacts with a blood vessel wall, everything that follows lands differently. The evidence, the deficiency data, the practical implications, all of it changes when you understand not just that magnesium matters, but exactly why and exactly where in the body that conversation is happening every time your heart beats. Inside every blood vessel wall, there is a layer of smooth muscle cells whose job is to control the diameter of the vessel. When those cells contract, the vessel narrows and resistance increases. Blood has to push harder to get through, and pressure rises. When they relax, the vessel widens, resistance falls, and pressure drops. Blood pressure, at its most fundamental level, is a story about the state of those muscle cells at any given moment. Calcium is the signal that tells vascular smooth muscle to contract. When calcium ions flow through specialized channels in the cell membrane, they trigger the contraction cascade. This is precisely what calcium channel blocker medications target. They physically block those channels, reducing the calcium signal, allowing the smooth muscle to remain in a more relaxed state. And the result is vasodilation, lower resistance, and lower blood pressure. Magnesium works through the same gateway, but from the inside. It acts as a physiological antagonist to calcium, competing with it at the cell membrane channels, effectively functioning as the body's own calcium channel blocker. A 2024 review published in Frontiers in Physiology by researchers at the University of Pittsburgh's Renal Electrolyte Division described this in precise mechanistic terms. Magnesium modulates vascular tone by altering the activity of L-type calcium channels and endothelial nitric oxide synthase, the enzyme responsible for producing nitric oxide, the molecule that signals blood vessels to dilate. When magnesium levels are adequate, nitric oxide production is supported, vascular tone is modulated, and the blood vessel maintains appropriate flexibility. When magnesium is depleted, the calcium signal goes relatively unopposed, nitric oxide production is impaired, and vessels tend toward a state of increased tension. But the cardiovascular role of magnesium extends beyond the vessel wall itself. The same 2024 review identified a second mechanism. Magnesium blocks N-type calcium channels at the endings of sympathetic nerves, the nerves that release norepinephrine, the hormone that drives the fight-or-flight stress response and raises blood pressure. When magnesium is sufficient, it dampens this sympathetic signal. When depleted, the sympathetic nervous system runs with less of its natural brake applied. Blood pressure climbs not just because vessels are tighter, but because the hormonal accelerator is being pressed more firmly and the physiological brake is partially missing. There is also a third pathway, more recently characterized. Magnesium influences aldosterone secretion from the adrenal glands. Aldosterone is the hormone that tells the kidneys to retain sodium and water, which increases blood volume and therefore pressure. Magnesium depletion has been shown to promote elevated aldosterone activity, creating a situation where the body holds onto more fluid than it should, adding volume pressure to the tension pressure already building from impaired vasodilation and elevated sympathetic tone. What emerges from these three converging mechanisms, vascular tone, sympathetic nervous system activity, and aldosterone-driven fluid retention, is a picture of magnesium as something closer to a systemic cardiovascular regulator than a simple nutrient. Its absence doesn't just leave one gap, it leaves several operating simultaneously, each reinforcing the others. And for adults over 50, whose bodies are already navigating hormonal shifts, declining kidney efficiency, and the accumulated mechanical wear of decades of cardiovascular demand, the compound effect of these gaps is not trivial. The question this raises, and it is worth sitting with, is how so many people managing hypertension have arrived at a conversation dominated entirely by sodium and medication, without anyone pausing to ask whether the body's own calcium-blocking mechanism might be running low on the mineral it needs to do its job. Your doctor has almost certainly checked your magnesium level at some point. If the result came back normal, you were probably reassured, and the conversation moved on. What you were likely not told is that the test used to make that determination, serum magnesium, a measurement of magnesium concentration in the blood, reflects less than 1% of the total magnesium in your body. The other 99% is stored in bone, muscle, and soft tissue, where it does the actual biological work. And according to the NIH Office of Dietary Supplements, normal serum magnesium levels can be maintained even when intracellular stores are significantly depleted. The blood protects itself. The tissues go without. This is not a minor technical footnote. It is a fundamental limitation of the most commonly used clinical assessment for a mineral that participates in more than 300 enzymatic reactions in the human body. A 2018 review published in Open Heart described this gap in clinical terms that are difficult to misread. The normal reference range for serum magnesium was derived from population distribution data, not from levels associated with optimal physiological function. In other words, what the test calls normal was never defined as healthy. It was defined as average. And average, in a population where dietary magnesium intake has been declining for decades, may not be the same thing. The scale of the deficiency problem is significant. Research analyzing data from more than 5,000 adults in the National Health and Nutrition Examination Survey found that nearly 68% of U.S. adults may be at risk for chronic latent magnesium deficiency, meaning their blood levels appear within the normal range while their tissue stores are depleted. A separate analysis estimated that 45% of Americans are magnesium deficient by any measure, and that 60% of adults do not reach the average dietary intake recommendation. The recommended daily intake for adults over 50 sits between 320 and 420 milligrams per day. National dietary surveys consistently show average intake falling well short of that target. For adults over 50 specifically, several factors converge to make this gap worse. Magnesium absorption in the gastrointestinal tract declines modestly with age. The kidneys, which regulate magnesium retention, become less efficient at conserving the mineral as they age. And many of the medications most commonly prescribed to older adults, including thiazide diuretics, which are among the first-line treatments for hypertension itself, actively promote magnesium excretion through the urine. This creates a situation of particular irony. One of the most commonly prescribed blood pressure medications accelerates the loss of a mineral whose deficiency contributes to elevated blood pressure. Proton pump inhibitors, widely used for acid reflux, and among the most prescribed medications in the country, have also been associated with significant magnesium depletion with long-term use. The NIH has issued formal guidance acknowledging this interaction. Yet the connection between these medications and magnesium status is rarely part of the routine conversation when prescriptions are written or renewed. What this means for someone over 50 managing blood pressure is that a standard blood test showing normal magnesium provides significantly less reassurance than it appears to. The test was not designed to detect the kind of suboptimal tissue-level depletion that influences vascular function. It was designed to detect severe clinical deficiency, a different and much rarer condition. The gap between those two thresholds is precisely where most people with developing magnesium insufficiency live, undetected and untreated, often for years. And the clinical consequences of living in that gap, as the research makes increasingly clear, are not trivial. The scientific literature on magnesium and blood pressure has been accumulating for decades. What makes it complicated, and what has kept it from translating cleanly into clinical practice, is that the evidence is real but not simple. The results vary across studies, The effect sizes are modest in some populations and substantial in others, and the relationship between magnesium status and blood pressure response turns out to depend heavily on factors that most studies don't fully control for. Understanding what the evidence actually says, without overstating it or dismissing it, requires holding that complexity honestly. And the most rigorous recent synthesis comes from a meta-analysis published in the journal Hypertension, the flagship publication of the American Heart Association, analyzing 38 randomized controlled trials involving 2,709 participants. The findings showed that magnesium supplementation produced a statistically significant reduction in systolic blood pressure of 2.81 millimeters of mercury and diastolic blood pressure of 2.05 millimeters of mercury compared to placebo. Those numbers deserve context. A reduction of 2 to 3 millimeters of mercury in systolic pressure is modest at the population level. But at the individual level, particularly when sustained over time, reductions in that range are associated with meaningful decreases in cardiovascular event risk. And crucially, the same meta-analysis found that the effect was substantially larger in specific subgroups. Among participants who were both hypertensive and had documented low magnesium levels, hypomagnesemia, the systolic reduction reached 7.68 millimeters of mercury. That is a clinically significant number. It sits in the range of what a single antihypertensive medication produces in many patients. For a mineral delivered through supplementation, without the side effect profile of a pharmaceutical drug, that effect size in the right population is worth taking seriously. A parallel umbrella meta-analysis published in 2024, synthesizing 10 prior systematic reviews, encompassing 8,610 participants, reached consistent conclusions. Magnesium supplementation produced significant reductions in both systolic and diastolic blood pressure across the pooled data. The consistency across independent research groups reviewing overlapping but not identical bodies of evidence strengthens the signal. This is not a finding from a single well-publicized trial. It is a pattern that has emerged repeatedly across different populations, different dosing protocols, and different research teams. The evidence also shows something important about who benefits most. The blood pressure response to magnesium supplementation appears largest in people who are magnesium deficient to begin with, which brings the argument full circle to the previous block. If the majority of adults over 50 are walking around with suboptimal tissue magnesium that standard testing cannot detect, then the clinical trials showing modest average effects may be substantially underestimating the benefit available to the people most likely to be watching this video. The average effect across a mixed population of deficient and replete individuals will always look smaller than the effect in the subset that actually needs the intervention. What the evidence does not support is treating magnesium as a replacement for prescribed antihypertensive medications in people who need them. That is not what the research says, and it is not what this video is suggesting. See, what it does support is treating magnesium status as a variable that belongs in the conversation about blood pressure management, one that is currently absent from most of those conversations, and whose absence may be leaving a meaningful lever unpulled. That lever, it turns out, operates not just on blood pressure directly, but on the physical structure of the blood vessels themselves, in a way that the pressure reading on the cuff cannot capture. Blood pressure is a number. It tells you something real and important about the force your blood exerts against vessel walls at a given moment. But it doesn't tell you everything about the condition of the vessels themselves. Two people can have identical blood pressure readings while their arteries are in meaningfully different states. One with flexible, responsive vessel walls that accommodate changes in blood flow smoothly, and one with stiffer arteries that transmit pressure less efficiently, demand more cardiac work, and carry substantially higher long-term cardiovascular risk. The number on the cuff captures the pressure. It doesn't capture the stiffness. Arterial stiffness is one of the most significant independent predictors of cardiovascular events: heart attack, stroke, and cardiovascular mortality that most people have never heard of. It is measured clinically using pulse wave velocity, a technique that assesses how quickly a pressure wave travels through the arterial system. Stiffer arteries transmit that wave faster, and a faster velocity is a worse outcome. Longitudinal epidemiological studies have found that a decrease of just 1.0 meters per second in pulse wave velocity corresponds to a 14% reduction in cardiovascular event risk. That is a substantial effect from a single biomarker shift. Magnesium's relationship with arterial stiffness is one of the more compelling and underappreciated findings in the cardiovascular literature. A 24-week randomized, double-blind, placebo-controlled trial conducted at Maastricht University enrolled 52 overweight and slightly obese adults with an average age of 62, a population profile that maps closely onto the people most likely to be watching this video. Participants received either 350 milligrams of elemental magnesium daily or a placebo. At the end of 24 weeks, the magnesium group showed a clinically relevant reduction in arterial stiffness, as measured by pulse wave velocity. Blood pressure did not change significantly in this particular study. The vessels became more flexible before the pressure reading registered a change, suggesting that magnesium's cardiovascular benefit may be operating at a structural level that precedes what standard monitoring captures. This distinction matters enormously for how people think about what they are managing. If arterial stiffness is building silently while blood pressure numbers remain borderline or controlled, the cardiovascular risk is still accumulating. A blood pressure medication that brings numbers down without addressing underlying vascular stiffness is managing the measurement without fully addressing the biology. Magnesium, by contrast, appears to work on the physical properties of the vessel wall itself. Through mechanisms that involve calcium regulation in vascular smooth muscle, nitric oxide-mediated effects on vessel elasticity, and anti-inflammatory pathways that reduce the chronic low-grade vascular inflammation increasingly recognized as a driver of arterial aging. A research published in Frontiers in Cardiovascular Medicine identified a specific inflammatory mechanism connecting magnesium deficiency to hypertension that goes beyond simple vasodilation. Magnesium depletion activates the NLRP3 inflammasome, a component of the innate immune system that, when chronically activated, promotes vascular inflammation and contributes to the arterial changes associated with sustained high blood pressure. This pathway is distinct from the calcium channel mechanism described earlier. It represents a second, parallel biological argument for why magnesium status belongs in the conversation about cardiovascular aging. For adults over 50 managing blood pressure, the practical implication of this evidence is that the goal is not simply to produce a lower number on a cuff reading. It is to maintain blood vessels that remain structurally capable of doing their job well for the next 2 or 3 decades. The number matters. The vessel matters more. And the mineral that supports both the pressure regulation and the structural integrity of the vessel wall is, at this moment in most clinical conversations, not being discussed. What happens inside those vessels at night, and how magnesium status shapes the body's overnight cardiovascular behavior, is the piece of this story that most people find the most surprising. Most people think about blood pressure as a daytime concern. You check it in the morning, track it at appointments, adjust medications based on readings taken when you are awake and upright. What receives far less attention in clinical conversations, in patient education, and in most discussions of cardiovascular risk is what blood pressure does at night, and what determines whether it does it well or badly. Under normal physiological conditions, blood pressure follows a circadian rhythm. It drops by roughly 10 to 20% during sleep, a pattern called nocturnal dipping, and rises again in the pre-dawn hours as the body prepares for waking. This dipping pattern is not incidental. It is an active, regulated process that gives the heart and blood vessels a period of reduced mechanical stress, during which repair processes occur and inflammatory markers trend downward. People who maintain normal nocturnal dipping have meaningfully better cardiovascular outcomes than those who don't. Non-dippers, people whose blood pressure fails to fall adequately during sleep, show higher rates of left ventricular hypertrophy, stroke, and cardiovascular mortality. independent of their daytime blood pressure levels. Magnesium is involved in this nocturnal regulation through several converging pathways. The first is its role in sleep architecture itself. Research published in NIH-indexed literature has documented a bidirectional relationship between magnesium status and sleep quality. Magnesium acts as a natural antagonist of NMDA receptors and an agonist of GABA receptors, the inhibitory neurotransmitter system that promotes calm and supports the transition into deep restorative sleep stages. When magnesium is depleted, this inhibitory tone is reduced. The nervous system runs hotter at night. Slow-wave sleep, the deepest and most cardiovascularly restorative stage, is shortened or fragmented. And the nocturnal blood pressure dip, which depends on genuine physiological rest, becomes shallower or disappears. The second pathway involves cortisol and the sympathetic nervous system. During disrupted or insufficient sleep, cortisol levels remain elevated into hours when they should be falling. Elevated nighttime cortisol keeps the sympathetic nervous system partially activated, sustains vascular tone, and blunts the nocturnal blood pressure reduction. Magnesium supplementation has been shown in clinical studies to improve sleep efficiency, reduce insomnia severity scores, and restore more normal cortisol and melatonin rhythms, with downstream effects on the cardiovascular environment that sleep quality is supposed to create. The third pathway is inflammation. Magnesium deficiency promotes the activation of pro-inflammatory pathways, including the NLRP3 inflammasome described in the previous block. Chronic low-grade inflammation does not observe a sleep schedule. It runs through the night, maintaining a vascular environment of elevated tension and reduced repair capacity. Adequate magnesium status, by dampening these inflammatory signals, supports the overnight shift toward the lower pressure. To lower inflammation state that cardiovascular tissue needs to maintain long-term resilience. For adults over 50 whose blood pressure is controlled during the day but who sleep poorly, wake frequently, or feel unrefreshed regardless of how many hours they spend in bed, the connection between magnesium status and overnight cardiovascular health is more than theoretical. The nocturnal cardiovascular environment is shaped, in part, by the minerals available to regulate it. And a mineral that supports vessel relaxation, sympathetic dampening, restorative sleep architecture, and anti-inflammatory overnight biology is doing a great deal of quiet work. Work that stops happening when the mineral isn't there. Understanding what to do with this information requires knowing where magnesium actually comes from, how much of it survives modern food and modern digestion, and which forms of supplementation the science actually supports. Magnesium is not a rare mineral. It is present in a wide range of whole foods. Dark leafy greens, legumes, nuts, seeds, whole grains, dark chocolate, avocado, and certain fish. In a diet built around minimally processed whole foods consumed in adequate quantities, reaching the recommended 320 to 420 milligrams per day is achievable. The problem is that most American diets are not built that way, and the foods that contain the most magnesium are, with some consistency, the foods that appear least frequently on the average plate after 50. There is also a structural problem that precedes the plate entirely. The magnesium content of fruits and vegetables grown in contemporary agricultural conditions has declined significantly compared to produce grown in the early 20th century, with some analyses suggesting reductions of 80% or more in certain crops. Modern industrial farming methods, which prioritize yield and appearance over mineral density, have progressively depleted the soil magnesium that plants draw on. A serving of spinach today contains measurably less magnesium than a comparable serving did 50 years ago. You would have to eat substantially more of the same food to get the same mineral yield. And most people are not doing that. For adults over 50 who cannot consistently reach adequate intake through diet alone, which, given the data on average consumption, describes the majority. The question of supplementation becomes practical and worth addressing with specificity. Not all supplemental magnesium is equivalent. The form matters considerably, and the difference between forms is not trivial. The NIH Office of Dietary Supplements has published clear guidance on this question. Forms of magnesium that dissolve well in liquid are absorbed more completely in the gut than forms that do not. Magnesium oxide, the most common and least expensive form found in pharmacy supplements, has low solubility and consequently poor bioavailability. Research comparing magnesium oxide to organic forms found that oxide was only 43% soluble even under peak acid secretion conditions in the stomach. Magnesium citrate, by contrast, they showed 55% solubility in plain water before stomach acid was even a factor, and substantially higher overall absorption in controlled studies. A randomized trial comparing 3 forms found that organic compounds, including citrate and amino acid chelate, showed significantly greater absorption at 60 days than magnesium oxide. Magnesium glycinate, bound to the amino acid glycine, is similarly well absorbed and carries the additional advantage of being gentler on the gastrointestinal tract, less likely to cause the loose stools that higher doses of citrate can produce in sensitive individuals. Several factors interfere with magnesium absorption, regardless of form. High-dose zinc supplementation can disrupt magnesium balance. Alcohol promotes urinary magnesium excretion. And the same thiazide diuretics and proton pump inhibitors discussed earlier in this video continue to drain magnesium even when supplementation is underway, which means that people on those medications may need higher baseline intake simply to maintain adequate tissue levels, not to build them up. This is a conversation worth having with the prescribing physician, because the interaction between common medications and magnesium status is real, documented by the NIH, and rarely discussed at the point of prescribing. What this means in practice, for someone over 50 trying to close a gap that diet alone may not be closing, while taking medications that actively widen it, is that the question of magnesium status deserves more specific attention than most clinical conversations currently give it. Not as a wellness afterthought. As a variable with documented cardiovascular consequences, a documented assessment problem, and a documented set of practical responses, all of which leads directly to the conversation most people with high blood pressure have never had. The clinical conversation that most people with hypertension have never had goes something like this. Not a conversation about switching medications or abandoning treatment. A conversation about whether the current approach to blood pressure management is accounting for all the variables that influence it, and whether magnesium status is one of those variables that deserves attention in this specific body, with this specific medication history, at this specific stage of life. That conversation starts with an honest acknowledgement of what the evidence supports and what it does not. Magnesium supplementation is not a treatment for hypertension in the way that amlodipine or lisinopril is a treatment. The research does not support stopping prescribed medications in favor of a mineral. What it does support is a more complete picture. Magnesium status influences blood pressure through multiple simultaneous mechanisms. Deficiency is common and routinely undetected by standard testing. Several commonly prescribed medications deplete magnesium as a side effect, and supplementation in deficient populations produces clinically meaningful blood pressure reductions, with the largest effects in people who need it most. For someone over 50, taking a thiazide diuretic for blood pressure, a proton pump inhibitor for reflux, and perhaps a statin for cholesterol, a combination that describes tens of millions of Americans, the cumulative magnesium-depleting effect of those medications is not theoretical. It is pharmacologically documented. Suzanne, the physician managing the blood pressure, may not be the same physician managing the reflux, and neither of them may be specifically tracking magnesium status between visits. The person most likely to connect those dots is the patient, but only if the patient has been given the information to ask the question. Asking for a more complete magnesium assessment is a reasonable starting point. Serum magnesium, as established, has significant limitations. Red blood cell magnesium testing provides a more accurate picture of tissue-level status and is available through most clinical laboratories, though it is less commonly ordered in routine practice. Presenting this distinction to a physician, Asking specifically whether RBC magnesium might be worth checking, given medication history and cardiovascular concerns, is the kind of precise and informed question that tends to move clinical conversations forward. You are about 3/4 through this video. Subscribe before you move on, and pass this to someone managing blood pressure who has never heard this conversation. What comes next is where everything covered so far becomes something you can bring into an appointment and actually use. If supplementation is appropriate, the form and dose matter. The NIH recommends that supplemental magnesium from all sources should not exceed 350 milligrams per day without medical supervision, because higher doses can cause adverse effects in some individuals, particularly those with kidney disease. Organic forms, citrate, glycinate, malate, are meaningfully better absorbed than magnesium oxide, which remains the most common form in inexpensive supplements, despite consistently inferior bioavailability data. Taking supplemental magnesium in divided doses across the day, rather than in a single large dose, improves absorption and reduces the likelihood of gastrointestinal side effects. The dietary argument remains the foundation. No supplement corrects a diet that systematically excludes the foods that carry the mineral. Dark leafy greens, legumes consumed several times per week, a handful of nuts daily, whole grains that retain their mineral content arrive alongside fiber, potassium, and other minerals that synergize with magnesium in ways that isolated supplementation cannot replicate. What changes when a person walks into a medical appointment carrying this understanding is not the treatment. It is the conversation, and what that conversation can produce is exactly what the final part of this video is going to make concrete. There is a particular kind of frustration that belongs to people who have been doing everything they were told, who take their medications reliably, who reduced their sodium, who show up for their appointments and watch their numbers, and who still feel like something is missing from the conversation. Not because their doctors are indifferent, but because the framework within which those conversations happen was built without accounting for variables that the research has since made visible. Magnesium is one of those variables, and understanding it changes the quality of the questions you bring into the next appointment. The picture this video has assembled is not simple, and it was not meant to be. See, the mechanism is real and specific. Magnesium functions as the body's physiological calcium channel blocker through documented pathways involving vascular smooth muscle, sympathetic nervous system tone, aldosterone regulation, and inflammatory biology. The deficiency problem is real and widespread. Standard testing systematically underestimates it, common medications accelerate it, and dietary patterns in most adults over 50 do not reliably correct it. The evidence for cardiovascular benefit is real and growing, consistent enough across dozens of randomized trials and multiple independent meta-analyses to conclude that magnesium status belongs in the clinical conversation about blood pressure management, even if the conversation about exactly how to apply that conclusion is still being refined. And what the evidence does not support, and this matters, is the idea that magnesium is a substitute for medical treatment. Blood pressure management after 50 is a clinical responsibility that belongs between a patient and a physician. What this video has tried to do is give that conversation better raw material. A patient who understands the mechanism, who knows that their diuretic depletes magnesium, who asks about RBC magnesium testing rather than accepting serum results as definitive, who understands the difference between magnesium oxide and magnesium glycinate. That patient is participating in their care at a different level than one who has only ever been told to reduce sodium and take their pill. That participation matters, not as a form of resistance to medical authority, but as the kind of informed engagement that produces better outcomes. Because the physician who hears a specific, well-grounded question responds differently than the one who hears a vague concern. The quality of clinical conversations is shaped by the quality of the questions that enter them. And the questions that should be entering conversations about blood pressure management have been missing a piece that has been sitting in the peer-reviewed literature for more than 4 decades, undiscussed, while the framework stayed narrow. Think about what actually changes when a patient walks into an appointment knowing what they know now, not demanding anything, not rejecting their treatment, just asking, precisely and calmly, given my medications and my cardiovascular history, is it worth looking at my RBC magnesium? That question, backed by the understanding this video has provided, is different in kind from a vague wellness concern. It is the kind of question that opens a different kind of conversation, one that may reveal something worth knowing, or at minimum confirm that the current approach is already accounting for the variable. Either answer is useful. Neither is available without the question. The people who age well cardiovascularly are, in most cases, people who became precise participants in their own care, not passive recipients of it. That precision is not a product of medical training. It is a product of the kind of understanding this video was built to provide. If something here shifted how you think about your blood pressure, your medications, or a conversation you have been meaning to have, subscribe, share this with someone who needs it, and leave a comment telling us what you want us to go deeper on next. That is how this continues.